healthy neighborhoods, and I'm very excited to welcome you all to our May PRC Research Seminar. In today's seminar, Dr. Kim Mulsky will discuss burgeoning work that aims to address smoking disparities by attention to food insecurity as a key social determinant of health behavior. She'll present on 2 ongoing Cleveland-based pilot intervention studies to inform next steps in reducing smoking in Cleveland and beyond. We would also like to share the topic and registration link for next month's seminar. But before we do that, we'd like for you to connect with us. So if you haven't connected with us in the past, you can check us out at our website, www.PRCHN, or follow us on social. And as I was saying, we'd love for you to join us for our next month's seminar. This will be our last seminar for the academic year until we return from summer break. This next month's seminar in June will be co-sponsored with the Clinical Translational Science Community and Collaboration Core. We'll be having Dr. Ronas, Dr. Ross, and Dr. Colton present on their pilot work in asthma and social determinants of health. We've put the link to that seminar into the chat box, and we would encourage you to go ahead and click there and get registered now. One last bit of housekeeping before we get started. One of the things we all miss about in-person seminars is getting to introduce one another and meet new people. So in order to facilitate that, we ask that you please add your name and organization into the chat box today to introduce yourself to others that are joining the call. And maybe you'll get a chance to connect in the chat. We'll also use the chat feature to type in questions during the seminar. And now I am very excited and honored to introduce my friend and colleague, Dr. Kim Mulsky. Dr. Kim Mulsky is an assistant professor in the Department of Population and Quantitative Health Sciences here at Case Western Reserve University School of Medicine. She received her PhD in social psychology from the University of California, Davis, where she focused her dissertation on disparities in access to mental health treatment for Asian American populations. Her current research program examines socioeconomic and racial ethnic disparities in tobacco use and smoking cessation. She's particularly interested in the intersection of food insecurity and smoking, as well as promoting smoking cessation in populations who disproportionately face tobacco-related health problems. I have to share a personal story that Jen attended a seminar that I gave on a similar topic a few years back now. And it's actually what I think drew her to apply to an open faculty position here at the PRC. And so it's been such a wonderful series of events to have a colleague study a topic that is so near and dear to me and to the focus of the research of the PRC. Her work draws on a range of social and behavioral science research methodologies, including mixed methods towards conducting community-based research with implications for policy. Prior to joining us here at Case Western Reserve University in the PRCHN in 2020, Jen was an assistant professor at the University of Massachusetts Amherst, her undergraduate alma mater. And yes, she joined us in 2020, just prior to the pandemic. So it's been nice to be able to get back and doing things in person. So Jen, I will turn off my share screen and I will gladly turn it over to you for your wonderful presentation.
Thank you so much, Dr. Trappel. And as I pull up my screen share, I was thinking to myself as I was putting my slides together that the last time I spoke formally at the Prevention Research Center was for my job talk. And so it was such a great opportunity to reflect on what we've been able to do since I joined in 2020 and sort of all the work that's left to do. So thank you so much for this invitation and having me here. So let me pull up the slides. I trust that you're able to see the slides and can hear me okay. And if you at any point you can't, then somebody will say something and speak up. So thank you again for having me and for every one of you that's in today's call and that's joining us here today. Just to give a brief overview of today's presentation, I'm going to start by giving a brief background on tobacco use disparities and the relevance of food insecurity and talking about each of these areas. And as you can see in this kind of figure, I focus on this intersection of tobacco use disparities and food insecurity and the relevance of food insecurity. So today, as part of today's talk, I'm going to talk about that intersection and not so much about the epidemiological studies on the association, which is something that I've talked about previously, and there's a lot of published work on that area, but rather I want to focus today on the lived experiences, the contextual factors of smoking and of food insecurity and the role of structural disadvantage through qualitative work, and how that work has then informed the intervention approaches that I'm going to talk about in the pilot work. That's kind of the meat of today's presentation. And so one caveat that I'll draw is that I'm really talking about, when I say tobacco use, primarily I'm talking about cigarette smoking, and this is among adults. And there's many different types of tobacco product use, as many of you may know, and there's different issues of different age groups. But for me, in this talk, I'm primarily focusing on cigarette smoking among adults. So with that, here's a tagline that you may have seen in different types of presentations or papers, and it's really that tobacco is not an equal opportunity killer. And we've had a lot of national level reports, the Surgeon General's report and the National Cancer Institute, highlighting all the successes of tobacco control, such that we've had major reductions in tobacco use prevalence since its peak in the 1960s. But since then, even with that reduction, now we're left with tobacco use disparities that are not random, but it's disparities across groups by race, ethnicity, education level, socioeconomic status, and so on. And I just want to highlight here, I think many of us already know this, but just to bring this point home, that the burden of cigarettes is extremely high to society, even when the cigarette use prevalence has gone down. So about 29% of cancer deaths that are related to smoking are attributable to cigarettes. And then 12% of annual healthcare spending in the US is also attributable to cigarettes. So these are important estimates for us to keep in mind in the burden of smoking. And I think in this audience, for many folks that are here in Cleveland, maybe this is not something I need to really just harp on, but I did do my training in California, where smoking prevalence is much lower than other parts of the country. So I'm pretty used to having to convince people this is an important area that we need to continue to focus on, and particularly the tobacco use disparities. So it's not that we don't know how to treat tobacco use and dependence. You know, there are a wealth of evidence-based resources for tobacco use and kind of what works for whom and kind of the strength of the evidence. And this is just a snapshot of some of the resources that are out there where you can find evidence-based resources. So the Cochrane review, they have dozens of reviews on what works and to what extent they work. We've had the clinical guidelines for many, many years now on treating tobacco use and dependence. And then this is an example of Healthy People 2030, where you can gather evidence-based resources and understand what works and for whom. And yet the point that I'm trying to bring home is that despite us having these and having had these evidence-based resources for dozens of years now, we're really still left with this important issue of disparities in tobacco use. And this is one of the more recent figures that have come out from the National Health Interview Survey. And what you're seeing is the prevalence of any tobacco product use, any combustible tobacco product use, and cigarette use among US adults. And this is in 2020. And what you can just really clearly see is that the green bars are representing kind of overall prevalence of use. You can see with each of the blue lines, this income gradient in prevalence of tobacco use. So since I focus on cigarettes, if we go to the right-hand side, you'll see that, you know, cigarette smoking prevalence has reduced to 13%, and it was kind of hovering around 14 to 15% a few years before that. And so it's a great thing that it's down to 13%. And yet when we look at it by levels of annual household income, we see that 1 in 5 individuals who are earning less than $35,000 a year are smoking cigarettes, compared to just 6% of their counterparts who are in a higher income category. So really, and one thing I want to say here that these data are not showing is that if we do break this out by race and ethnicity, we're going to see similar types of income disparities across each race and ethnic group. So the question here is, why do socioeconomic disparities in smoking persist? There's a lot of different reasons why, but the main that I've been focusing on is the disparities in successful quitting. So what we know is that most people who smoke want to quit, and many of them try to quit each year, but what varies is the successful quitting. And it's real, so what we understand is it's really not in the trying, but it's in the succeeding. And so even though we've had a wealth of evidence-based tobacco cessation resources and interventions, this is something that Rosemary Hiscock and colleagues wrote about in 2012 that says tobacco control interventions are unlikely to be able to counter the embedded life patterns and underlying stress-causing conditions such as income instability, poor housing, and rundown neighborhoods. And this was in a review article of smoking and socioeconomic status. So we're cognizant of this from many years ago. I just wanted to bring up this article here. This came across my news feed, NBC News article. And if you look at the headline, it's, Los Angeles agrees to spend $3 billion to house residents with homelessness. And the reason why I kind of stopped short at this and took a screenshot of this page was because of both the figure and the caption. So you may not be able to read the caption, but the caption here says, Bobby Rojas smokes in his tent amid a homeless encampment on Skid Row. And so to me, this really hones in on this inextricability of smoking and of poverty and of these structural conditions. And this was a really relevant example that has just shown up, very recently. And this is just one example of that. So back to this question of why do socioeconomic disparities in smoking persist? Well, I particularly have been drawing from the fundamental cause theory as of late, and it's not a new theory. Many of you here in the audience may be familiar with it, and it's from sociologists Bruce Link and Joe Phelan. And what they ask is, what are the risk factors for the risk factors? And if we're thinking about smoking and tobacco use as a risk factor for poor health, the fundamental cause theory would say, what are the risk factors for tobacco use? And rather than the focus on individual risk factors, for instance, they focus on the systems of exposure or the systemic factors that shape or constrain health behavior. So with that in mind, here's a relatively new article, recent article in Tobacco Control by Sarah Mills and colleagues. And I'm not a systems dynamic scientist, and this is not the methods that I draw from, but I particularly was interested in this paper because they were drawing on what are the fundamental causes of smoking. And so I encourage you to check out the full article should you be interested. And I'll just highlight the main point that I want to show here, which is the fundamental causes of smoking are the bullet points that you see here. And the figure to the right, it's not meant for you to be able to read this necessarily, but all the red text that you can kind of squint and see, those are the fundamental causes of smoking. And they drew out this model of how each of these factors relates to more proximal factors that then relate to smoking. And so for me, while this article is from 2021 and it's a newer article, I've been thinking about this since my postdoc years and when I started that around 2015. And since then, I've been really interested in this area of financial strain. So financial strain, as far as I know, and if anybody here in the audience has a different take on it, then please let me know. But as far as I know, there's not quite a standard definition of financial strain. But when I look at the literature and how folks tend to define it across studies, it's usually defined as difficulty affording food, clothing, housing, bills, and other needed items. So it's this really catch-all phrase, catch-all concept rather. And other studies may operationalize it as, did you have problems paying bills and so on. And so one area, a very specific area of financial strain that I'm particularly interested in, where we do have a definition and we do know that it's related to many types of poor health outcomes and health behaviors, is food insecurity. So food insecurity, we know it occurs when there is this limited or uncertain access to enough food due to lack of money or other resources. And this bar graph that you see, this is the USDA figures that they release year after year on the national prevalence of food insecurity in the US. And what you'll notice is that from 2007 to 2008, we had this really sharp increase in levels of food insecurity due to the economic recession. And we're looking at this dark blue line. And many of us who are doing this work and really paying attention to food insecurity wondered what would it look like between 2019 and 2020 when we had the pandemic and we had a lot of food insecurity that occurred across the population. That was the focus of a different talk that I gave recently at the Society of Behavioral Medicine. So I'm not going to get into that here. That's more in that epidemiology space. But if anybody is interested, I'd be happy to share, the work of that's forthcoming. And just as a reference, while the Healthy People 2020 target for food insecurity is 6%, so we have a lot of ways to go to reach that. And so the overall prevalence of food insecurity in 2020, just across the US population, was around 10.5%. If we do break this out by federal poverty level, of course, we see some stark differences or stark disparities in level of income or poverty and experience of food insecurity. So for those who are earning less than 100% of the federal poverty level, the prevalence of food insecurity was over 1 in 3 of those households. And just as a reference, federal poverty, it's for a family of 4, I believe it's around $26,000. For a single individual, it's around $12,000 a year. We also know that there are these racial and ethnic disparities in the experience of food insecurity. So these are all factors that many folks in the food insecurity space, focus a lot on. And for me, what my kind of unique lens to this work is that I combine food insecurity and smoking in understanding both of the phenomenon. So as I said, I'm not going to focus too much on the epidemiology of the work today, and I have a lot of different citations that you could and references if you are interested, but I hope that you'll take my word for it. The one figure that I will show is this work by Maggie Mayer, and what she did, and this was part of her dissertation work, she used data from the National Health and Nutrition Examination Survey and across these years of 1999 to 2014, and looked at all these different associations between tobacco product use and food insecurity. And what I'm highlighting here is that for each level of food insecurity, so from food security to low food security to very low food security, so that's talking about the severity of food insecurity, you see that smoking prevalence increases sequentially, and it's a very clear pattern. And this is higher smoking prevalence than what you would expect in 2020, just because of the time frame, this wide time frame, and this was a time in which there was a lot more smoking. And with more recent data, we would see similar patterns. And with any tobacco product use, it's the same type of pattern. And so without me going into all the epidemiology work and sort of what the quantitative studies have shown, I will kind of make a shout out to a review paper that a graduate student, Rajshri Pandey, and I worked on while I was at UMass Amherst, and it's now published in Health Promotion Practice, and it's called The Intersection of Food Insecurity and Tobacco Use, where we did a review of all those studies on food insecurity and smoking. And so the overwhelming conclusion is that there's an association that these are risk factors for one another. And I also want to just highlight the Feeding America Food Security Evidence Review in August 2020. And the reason why I'm highlighting this is because as part of the evidence review and talking about the correlates of food insecurity, our quantitative research sort of made it into this document and this report, and highlighting that smoking is correlated with households experiencing food insecurity. So these are a couple, and I hope that you take my word for it, that the epidemiological associations are there and it's pretty strong. And we can talk more about that in kind of the discussion, but I'm not going to talk about it here as part of this talk. So instead, what I would like to do is talk about, share with you some work on the understanding the lived experiences of smoking and of food insecurity. And the reason why I find this to be so important is that I started doing this work using large national data sets. and doing this epidemiological work. And what that doesn't show are all the contextual factors that are associated and what is really the lived experience that these numbers are not quite showing. So I'd like to talk a little bit now about the qualitative work that informs this lived experience and how the role of structural disadvantage is incorporated here. So to better contextualize smoking and the experience of smoking and the experience of food insecurity and why they may co-occur and why they may overlap and intersect, we started with this broad research question of what are the experiences, perceptions, and contexts of tobacco use and cessation among people who smoke and are experiencing food insecurity. And we conducted some in-depth interviews that capture current circumstances and also people's life course histories. And I was very fortunate to be able to do this work in Western Massachusetts, where I was faculty at UMass Amherst. And we worked with Community Action Pioneer Valley, that is an economic justice organization that operates food pantries for folks who are in a rural setting. And so in order to do these interviews, we started with a needs assessment survey of pantry clients and to understand their needs, social and health needs. And then from there, we conducted in-depth interviews. We invited select individuals to do some in-depth interviews as they were willing to share their experiences and their life stories. So eventually we interviewed 23 people who are currently smoking. We also, and experiencing food insecurity. We also interviewed folks who are formerly smoking, but today I'm just talking about those who are currently smoking. So these are some of the themes, the main themes that came out of the interviews, and this was my first qualitative study, and boy, it was one of the hardest but most rewarding papers to write, I have to be honest. And so I'll go through each of these themes and talk a little bit more about the context of the themes. And one of the things that I was really struggling with as I was doing this work was to really give the participants justice in what they were saying and to make sure that none of the quotes that they were providing were taken out of context. So I'm going to go through each of these themes and then kind of give that contextual background. So the first theme that we found was folks smoking to ignore hunger or to eat less. The second theme was staying addicted to smoking in the midst of instability across many other facets of their lives. The third theme was smoking getting prioritized in the midst of financial strain. The fourth theme here was life stressors and the difficulty of quitting smoking and staying quit. And then the fifth theme was childhood adversity at this intersection of food insecurity and of tobacco use. And I was really fortunate to be able to work with some mentors that Dr. Susan Shaw is at UMass Amherst, and she is an anthropologist who mainly uses qualitative research. I also worked with Dr. Irene Yen, who is at UC Merced now, and she is a social epidemiologist who does qualitative work. So she has this very unique lens that she brings in the research methods that she uses. And you know, I was working with qualitative experts, and despite that, we found that it was really difficult to separate these into discrete themes. So you might be able to kind of pick up in the wording of these themes that, okay, how do they distinguish one another? And I'll talk just a little bit about that in the next few slides. But I will say that it's really, we conceived it as not a limitation of the work, of the research question, or let's say the methods, but it really illustrates that smoking and food insecurity are just inextricably connected to structural disadvantage. And so it was important for us to really spend a lot of time in this paper, even before we presented any of the themes, to give this backdrop of poverty and structural marginalization that came up in the participants' life histories and current circumstances. So by that, you know, a lot of folks were experiencing food insecurity in the midst of housing instability. So we had one participant tell us specifically, you know, it's not that I'm food insecure, and she used those words. It's not that I'm food insecure, but it's that I do not have a kitchen because I'm living out of my car. So even if I get food from my SNAP benefits, I just don't have anywhere to put it. It happened, so this intersection of food insecurity and smoking, also there was this reliable transportation and low access to reliable transportation. where people had to drive long distances to get to grocery stores. And if not, they often had to walk or rely on other people to give them rides as they could. Disability benefits, a lot of our participants, of the 23 participants, about half of them were living on disability benefits, which meant that they were navigating kind of this fixed income situation with poor health statuses, and that featured prominently across these interviews. And then lastly, this food assistance bureaucracy was an important backdrop to a lot of the interviews, in which folks would be on SNAP or not qualify for SNAP or go in and out of SNAP because of their life circumstances were changing. And I'll say just a little bit more about that in the next few slides. So what I wanted to do was just highlight one quote from each of these themes so that you can get a flavor for the depth and for the complexity of what's happening. And we're using pseudonyms for each participant. And so Julie, she is a participant in her mid-40s, and she has a young child. She's a single mother, and she says, smoking takes away my appetite because of growing up and not having food and stuff like that. So she's telling us about her upbringing and the circumstances that she had growing up. She says, I don't necessarily feel hunger, like I block it out, but it's obviously there. My body's hungry, I would like to eat. But on the times that I do feel hungry, if I smoke a cigarette, it goes away. I think I smoke more on the days that I don't eat, specifically if they've been multiple days. So she's telling us here that she has been explaining that there are days that she goes when she needs to make one kind of chicken breast really last for a few days at a time. And she does that to make sure that her daughter can eat, whereas she's really struggling, and she hides her food struggles from her daughter. Later in the interview, she shares with us that she needed to eat because she also has diabetes, and she's managing her diabetes. She gets low blood sugar because of the lack of food. And really the way that she combats that is through the peanut butter that she receives at the food pantry. So this is one kind of really poignant example of smoking to ignore hunger or to eat less because of this experience of food insecurity that is also overlaid with one's health status and the lack of resources around. In this next theme of staying addicted to smoking in the midst of financial strain, many participants described symptoms of addiction to cigarettes. So that means they continue to smoke despite knowing the negative consequences for themselves, and yet this theme was called this way because it seemed like there was so much instability in people's lives, and so smoking was that one kind of more stable component of people's lives that were precarious in many other ways. And this participant, Jan, also, again, these are all pseudonyms. She talks about how she's in between jobs right now, and the only source of income that she has is child support for her two daughters. And the amount of child support that she receives disqualifies her from receiving SNAP. And so she has a lot of this guilt. She talks about this guilt and shame of using the money that she receives from child support to buy cigarettes. I don't like doing that because then I feel even guiltier on top of the guilt that I smoke. So it's this really multi-layered experience of guilt and of smoking, and just all the contextual complexities around one's experiences. The next theme is smoking getting prioritized in the midst of financial strain. So this participant, Mel, she is living with her older parents who she has caretaking responsibilities of, and she works as an independent contractor. So that means her pay really fluctuates. And because of that, she stopped recertifying herself for SNAP because the process became so cumbersome, and many times she wouldn't qualify based on her past pay stubs, but she still experienced a lot of food insecurity in between. So she says here, I do try to smoke less when I know I'm going to be completely broke. Like I try to, it's hard. I often get stressed out about the fact that I don't have enough money for everything I need. And that just makes me want to smoke more. And what really jumps out to me about this is, in the in the literature on financial strain and tobacco use, we have this kind of concept called smoking-induced deprivation, where it's, if you think about the directionality of that term, smoking-induced deprivation, it kind of, in some ways, is very kind of victim blaming and kind of puts that kind of onus on that individual. Well, you're experiencing deprivation because of smoking. And really, what this highlights to me is that, you know, it's not that simple of a directionality. It's the lack of having things also makes you reach for a cigarette for stress relief and for other reasons, just that you don't have enough to make your ends meet. And that is a frustrating experience for many people. And one more quote that I'll share with this is, this participant, John, says, you know, people that are in my situation have financial burdens with the food and everything, but smoking is a big thing. And at one point, yes, it's expensive. It takes a lot out of your budget, but it also takes the worry away too. And this quote really stuck out to me because when we were doing these interviews, at the end of the interview, we always ask, like, you know, is there something that you wanted to say or that we didn't ask in this, you know, what else do you want to share with us? And it was in that moment that he brought this up. And so I hope that you all in this audience can help kind of think about this takeaway, that it's important to humanize individuals and to understand people's behaviors and context and kind of shift away from this victim blaming mentality of, oh, if only, you know, he would stop smoking, then he wouldn't have these financial burdens. And I'll say a little bit more about that as we go on. And then this fourth theme is around life stressors and the difficulty of quitting smoking and staying quit. So many of these participants were actively trying to quit and had numerous quit attempts in the past, but it was really something would come up and they would relapse into smoking. So this participant, Lisa, shares that, you know, she was preparing for surgery, and because of that, she quit and was able to stay quit for some time. And so she says, you know, after I quit the last time before surgery, that should have been it. But then we moved and all of the money I saved was stolen, and it could have been stolen by someone we lived with. So that was stressful because these were people I was supposed to trust. And once we moved into our own apartment, the stress of moving into our own apartment died down. So this strikes me because it gives me the sense of like, this participant is looking for the stability before they do something like stay quit. And this role of housing instability, maybe it's not housing insecurity, but this instability of moving from place to place was a big stressor in this person's life. And she talks about how they needed to take in a friend, and the stress of that really got her to start smoking again because of the stress of having somebody come live with you in a small place. And the last theme that I'll cover here in this particular, in this part of the talk is the childhood adversity at the intersection of food insecurity and tobacco use. And that was one thing, as we were doing these life course history interviews, it was really striking when people shared such poignant stories of what happened and how these formative experiences in their childhood. So this participant, Jenny, says, you know, I grew up with parents that were smokers, alcoholics, so it was always around us. And that's why addiction and smoking started early with me. It was always around us. And she talks about the abuse that her father enacted on her mother. And it wasn't until later that I realized you don't give teenagers or your children beer and liquor and cigarettes and stuff. So I find that I feel that my addictions were never my choice. Somebody else made the choice for me to be an addict. That is something because a child doesn't choose to be an addict. And so this was a really poignant passage that talked about the role of childhood adversity in kind of setting one up to continue to be smoking and to experience food insecurity and poverty and all sorts of these kind of current constraints. And with these 5 different themes that I've already said are not necessarily so clean in their discreteness, what we did in this paper was we developed this model. And as we're thinking about, you know, what do we do with these findings and how do we make recommendations and future areas of research, what you're seeing here on this diagram is it conceptualizes what we were finding in these interviews. And it does complement some of the quantitative research, but it gives a lot more contextual factors that we didn't have before this. And so this area of food insecurity, you see in these kind of concentric circles that nicotine dependence, or be it addiction, or as people are terming it themselves, be it smoking, it really overlaps with this experience of food insecurity and this experience of life stress. And they all really perpetuate and exacerbate one another. And while that is one's current experience, what's also happening in the outside, in the outset, are the role of social conditions, the role of one's health status, and their life course histories really converging into this cluster of nicotine dependence or addiction, food insecurity, and stress. So with this, where do we, how can we take some recommendations? How can we draw some recommendations and areas for research? So this is what we came up with in the paper itself. And I'll go through a couple of these, and it's not meant to be exhaustive, obviously, and it's ordered in a way that it's kind of the lowest hanging fruit to the biggest, most monumental change that you would need. So the first is to actively screen for food insecurity among people who use tobacco and vice versa, and being able to offer referrals for cessation assistance. Ensuring food sufficiency for people as they quit smoking. So recall again that most people who quit, or most people who smoke, are interested in quitting and they try to quit. And yet there are these barriers to doing so. So how can we ensure food sufficiency to reduce, let's say, sources of their stress? And these are other implications that you see here. So I'm going to talk about these in the as I talk more about the pilot work now in this last part of the talk. So as Dr. Erica Trappel mentioned as she was introducing me at the outset, so I joined CASE in January of 2020, and I was fortunate to have a career development award from the National Institutes of Health. It was really on this topic of food insecurity and smoking cessation. And there are a number of different aims that are associated, but the culminating aim was to leverage food assistance settings as a place to promote the use of evidence-based smoking cessation resources. And understanding that, many people who experience food insecurity are also going to food assistance settings. How can we leverage that setting to then connect people with resources? And with the notion of reaching people where they are, to connect them and to say, is this feasible? Is this acceptable? So I was very lucky to come to Case Western Reserve and Prevention Research Center to really embark on this work. And the text that you see kind of underneath this timeline is kind of how I had planned to do this work with the PRC and the relationships of the PRC. So to do a needs assessment survey, to then do some focus group, and then move on to smoking cessation outreach. And I'm sure at this point you may have some ideas as to what I'm going to say with some of the timelines, but we all know what happened in early 2020. And this was soon after I had arrived at Case Western Reserve, but still our team adapted and we were able to do this work of doing some needs assessment surveys of people who use food pantries. We did this kind of remotely with online surveys, telephone surveys. We then invited a subset of the participants to participate in focus groups with us, or which we call resident advisory groups, where we shared some of the findings of our survey and asked for their input in how we designed a smoking cessation outreach in food pantries. So this was really, I bring this timeline up to highlight that we were trying to figure things out and problem solve as we were going along. And this was, as many of you can relate, or probably all of you can relate, with the pandemic and kind of changing in research methods and so on, are really what I had wanted to do was go into our food pantries and do this work of engagement, and it wasn't possible to do this for obvious reasons. But still, we were able to do some of these needs assessment surveys. And while we didn't get like a huge sample, we were able to sample 191 individuals eventually. And so I'm just showing you a little bit of the findings around this, which was we did this work with the Hunger Network food pantries, and we did the needs assessment surveys of people who use food pantries. And so this sample was smaller than our overall sample. This is just 132 individuals. And what we're seeing here is that the prevalence of food insecurity was quite high. That only 17% had no levels of food insecurity. Everyone else, anywhere from mild, moderate to severe. When we look at tobacco use status among these individuals, 31% were currently smoking cigarettes, and 36% were using any tobacco. And this is not too different from what we found in our behavior risk factor surveillance system survey that the Prevention Research Center did in 2015. I think at the time it was 35% of Cleveland resident adults are currently smoking. So this is not too different from that. Just to kind of highlight this issue a little bit, when we look at the survey sample and looking at current smoking prevalence by food insecurity status, you'll notice that among those who were experiencing food insecurity, the prevalence of smoking was 13%, versus among those who are food insecure, the prevalence of smoking was 39%. And yes, this is a small sample, but nevertheless, we're seeing these huge differences. And then on the flip side, if we're looking at food security status by current smoking, among those who are non-smoking, 63% were food insecure, which is still extremely high. And yet when we're looking at the sample that we're currently smoking, it was 88% that are experiencing food insecurity. So I bring this up to highlight that these are issues that are just really tightly linked to one another. It's really not kind of a chicken or an egg kind of question. I hope that that's clear from some of the in-depth interview themes that I showed, but rather we know that these are clustering together. So what can we do about it? So this brings me to that culminating aim of promoting the use of smoking cessation resources in food pantries. As 2022 neared, we were able to start to kind of plan, okay, what would an in-pantry kind of outreach look like? And for those who may have familiarity with smoking cessation work, there is the ask, advise, and connect or refer, which is asking about tobacco use status, advising them to quit, and referring them to a service. Such as the quit line. And so for this particular study, we really leveraged on kind of asking and referring and using the food pantry as a setting to do this work. So I just want to make a big shout out to those individuals that were involved in any part of this work. We see here Erin, Tina, Katie, Allison, Maddie, and this is some of the work that we've been doing in this year, 2022, of going into our food pantries. We set up these tables and are kind of testing this feasibility of, can we connect people to resources in this setting? Here's an example on the right-hand side of a brochure that Allison Fallon, a nutrition student who was rotating with the Fetch team, as well as our PRC's Reach team, for some resources to give out in the food pantries. And when we're doing this kind of outreach events, you can see from the picture in the top left, our table is filled with not just smoking cessation resources or how to get connected to the quit line, but it was all around nutrition and kind of nutrition information. So a little bit more about the referrals to smoking cessation in food pantries. What are we referring folks to? I can sing the praises of the Ohio Tobacco Quit Line all day. I'm a huge fan of the quit line. Here's just a few pointers as to what makes the quit line so valuable. It's evidence-based and it's accessible to the population. It increases the chances of quitting successfully. Yet what's important about the quit line is that it is very much underutilized, and they offer many different things, many different services for residents: coaching over the phone, email, text, and chat coaching, education materials, quit planning materials, nicotine replacement therapy, and so on. and it's available to every resident of Ohio and to every, across the US, states have their quit lines. And before we kind of did this linkage to the quit line, as part of our needs assessment survey in the beginning, we asked this question of how familiar are you with the Ohio tobacco quit line? And so what you're seeing is that just a small portion of this sample said that they were very familiar, meaning that they heard about it and they have used it in the past. About half were somewhat familiar, so they've heard about it, but they've never used the services, and about a third were not familiar at all, so they hadn't heard about it and they had never used it. So this was really an opportunity to be able to do this. And so we started this work in early 2022, and I don't have like outcome data to show, but rather I do have kind of more meticulous numbers that we've been keeping track of, thanks to Katie Boyd, who's been working with us. And many congrats to Katie for graduating with her master's in clinical epidemiology. But let me walk you through some of these numbers here. So we've done 22 of these outreach events to date, and these aren't across 22 different pantries. We partnered with 4 different pantries, and we went to these pantries on different days that they were open and different times of the week and alternating weeks. And we estimated, we kept count of how many folks were coming through these pantries, and on the whole, we estimated a little over 600. We counted how many folks were visiting our table that had resources. You'll see there, assessing for eligibility as part of the study, which is to connect people to the Ohio tobacco quit lines, a smaller number. We had different eligibility guidelines. We have a consent form so that we can actually make the referral to the Ohio tobacco quit line and collect a bunch of baseline survey characteristics and follow them up over 3 months. But when you look at the number who's enrolled to the study to date, it's a small number. So if you go from the number of food pantry visitors of over 600 down to 19, you know, it comes out to like 3% or so. So it's actually quite small. Just because I like numbers, I'm looking at, you know, where are we kind of having some drop-offs, or where can we do a little bit better? And so you can get a sense that of the food pantry visitors, not everybody visits our table. And then among them, of course, we don't see that a lot of people smoke. But what's interesting is that you'll see the 31% here. And that does kind of correlate with the level of the prevalence of smoking that we found in our needs assessment survey and the BRFSS data that we have. And I also want to say that every food pantry in our area is quite different. And the 4 food pantries that we went to were also different in how they offer their services, how they've had to adapt in the pandemic, the amount of space that they have, all of those factors. So I just want to make a quick shout out to Amrutha Yarlagada, who did, as part of her MPH capstone, some interviews with these food pantry managers to understand kind of what their organizational priorities were. And with this bigger question of leveraging food pantries as a setting for health promotion, kind of zooming out a little more than just smoking cessation, but for health promotion. And so she interviewed 3 different food pantry managers, and it really varies. So on one hand, one food pantry manager says to us, you know, health is always an issue. We want to improve in the clientele. People are so weathered and worn from hard living. So they are absolutely interested in leveraging their setting as a health promotion setting. On the other hand, a different food pantry manager talks about how their service model does not work well for it. So what they're able to provide, the space that they have. And so there's a lot more to be said here, but in the interest of time, I'm going to just move on so that I have time to cover the next kind of pilot study that's ongoing. So this one is around ensuring food sufficiency for people as they quit smoking. As part of one of the papers that I'm working on with folks at the Institute for Hope at Metro Health is on social needs, the role of social needs and how that relates to smoking. And so we have this paper that we've written and is under revision now, where Metro Health, we're looking at the screening of their primary care patients and seeing that about a quarter of folks who have been screened for these social determinants of health needs have food insecurity. And you'll see these other figures here. And it's, this is going to sound like a broken record, but when we look at smoking prevalence by food insecurity screening prevalence, it's very clear that those who are experiencing food insecurity have twice the prevalence of smoking. And this is EHR documented smoking, by the way. So keep that in mind. And when we break this out by, let's say, the number of social needs, so most people had either 0, 1, or maybe even 2 social needs. But as you go up higher in the scale of social needs, it's very clear that we see this gradient. And so we are currently we've developed this intervention that we're currently running as a pilot study, and we're calling it the Food for Success study, Food Security for Successful Smoking Cessation. And really the motivating research question here is that if food insecurity is a barrier to quitting, then does addressing food insecurity during the cessation process improve cessation outcomes? And the work that I've done in this regard, in this area of study, I've been really focusing on the epidemiology and kind of highlighting the issue. And then as I've been doing that work, it really got me thinking that how can we start to intervene? What programs can we develop? How can we start to do something about this? So that was really the motivation, the driving motivation behind this. So we designed an intervention that leverages a community health worker as a navigator that links participants with tobacco cessation resources and food assistance resources. I won't have time to kind of go over all the details here in today's talk, but this pilot study is designed as a 12-week study, and every participant gets 3 contacts with a community health worker. And so for the reasons of getting in touch is the community health worker will connect the participants to tobacco cessation resources that you see here, as well as food assistance resources that are available through Metro Health and through the broader community. And the way that this study is set up is that folks take a baseline survey, and then they'll have a first call with a community health worker where everybody's offered all of these different referrals for cessation and food assistance. A month later, there's a follow-up to then say, hey, how have you worked? How have this worked for you? So on. There's another follow-up call, and then there's a 3-month survey. And so, as I mentioned, this is a 2-arm pilot RCT. So what is the randomization piece? So for this particular study, we are providing economic support for food and groceries for folks who are randomized into that group. And so as a pilot study, it's not very long, it's 3 months, and that economic support is in the form of a flexible debit card. I use the term flexible, sort of borrowing from my colleague, Juliana Nemeth at Ohio State University, where it's a debit card where we're saying this is for your food and this is just support your food and support your groceries. But on the other hand, we know that there's so much more to food insecurity than just food. Perhaps it's gas and all of these other types of needs. So folks receive this debit card, and then I just want to point out that, yeah, by definition, food insecurity occurs due to a lack of money. So this is the intervention piece that folks in the intervention group are receiving. I'll say a little bit about where we are now. We just launched this, and it only started in February 2022. We're doing this in waves. And so this is just for the wave 1 recruitment. We're already past wave 1, we're in wave 2. So the numbers are slightly different, but what you'll see here is just the study flow. We have a process in which we're generating a pre-screening list using the electronic health record. As a feasibility and pilot study and protocol development study, we're really focused on kind of making sure that we can do this before we scale it up. So that's why you see the sending mailers with study info. We started with this 150 individuals and try to understand some of the recruitment rates and attrition rates and so on. So for wave 1, we were able to assess 55 individuals for eligibility. Of them enrolled 14, and you'll see that 7 are in the intervention, 7 are in the control. At this point, we're a little bit higher than this number because we have been moving on to the subsequent waves. So please stay tuned as to what you're going to see with this particular study, but I want to highlight a few things that, our wonderful, wonderful community health worker, Pat Hardy has been kind of noting in the call logs. And to me, this is such valuable information. She says, this is about somebody in the control group. The participant was going to food pantries, but was not receiving food that is gluten-free. So this person needed gluten-free for their own health reasons. And so Pat made a referral to Food as Medicine, which is Metro Health's internal kind of food as medicine clinic for folks who meet certain chronic health conditions. And then she says, of the Food as Medicine clinic referral, the program is working well for her. She's able to receive gluten-free food. So even folks in the control group are getting some benefit. That's how I interpret this. This is a control group participant also who Pat writes the notes of. She connected with the Ohio Tobacco Quit line. She said a quit day has been cutting back on smoking. Pack of cigarettes is lasting 3 days instead of 1. And then that's just kind of the last piece that I'll say is that this is from an intervention group participant who says, the debit card is very helpful. She had bariatric surgery 3 years ago, and the debit card helps her to buy protein drinks. And she had declined a food bank referral, and we keep track of all of these things in our call logs, which are pretty extensive. And so Pat writes that, she finds a food bank and pantry is useful, but because she has to eat smaller portions, she doesn't want to waste the food that's given to her. So this really, to me, highlights the importance of being able to individualize some of this to the extent that we can, and really understand people for who they are as people. Okay, so I know I'm at time now, and I just want to kind of round this out and take 1 minute to kind of come back to how I started this presentation. And I talked about this intersection of tobacco use and food insecurity. And what is it really that drives me, and how did I come to become so interested in this intersection that I've devoted so many years of my career, and I continue to want to do this area of work. So I want to kind of just very briefly tell you a little bit about my story, which was, as Dr. Erica Trappel mentioned in the beginning when she was introducing me, that I had done my dissertation or my PhD in social psychology studying mental health treatment disparities among Asian Americans. And so our family history was that this photo that you're seeing, I'm the one with the red shorts. This was circa 1991 when we had first immigrated to Guam from South Korea. And so our story was very much intertwined with this kind of immigration, culture, and language barriers, but at the same time navigating this mental health and mental illness in our family and experiencing a lot of instability that came from that. It was around this time that my mom was showing a lot of signs of her declining mental health. And so she was really she really needed help, and yet we didn't know where to turn for help, nor did we have the resources, nor did we just know where to go. And there was a lot of stigma in the community. And so I devoted my dissertation to understanding, why don't people seek help even when it is available and when it is accessible? So that was the main question that I sort of focused on in this kind of psychology space. And eventually, as I was doing that, it was like, well, there's so much more to this. And so I started becoming really interested in access to services, where to go, the use of services, getting the full benefits. And there were so many parallels to smoking and smoking cessation and tobacco and just health disparities as a whole. So one of the things many of you are familiar with Maslow's hierarchy of needs, right? And so in order for everybody to be able to self-actualize and become the best that you can, there are all these other things that need to be met in the process. So that's really what drives me and the work that I do in this kind of intersection of tobacco use and food insecurity. And so lastly, just special thank you to everybody, to all of you here in today's call, spending this time with us, and congrats to Katie, who just graduated, and Ruth, everybody just pictured here. And lastly, thank you so much.
Thank you, Jen. And I encourage everyone to come back on camera and unmute and give Jen a round of applause. So I'll just start. That was fantastic. We have time to take questions. If anyone would like to lead us off, you can either type your question into the chat box, or you're welcome to take yourself off of mute and ask questions.
Was
I
that
will ask,
clear,
but
huh?
I don't want to hog the time because I know where Jen's office is, but anybody?
So I'll ask a question.
Thanks.
We're coming to this point where we're seeing a lot of inflation, especially around food. How do you account for that, or have you thought about that as far as how that'll affect your studies at all?
Yeah, definitely. I thought about it, but I don't have a good answer. Um, maybe Derek, you have somebody else in the audience has a better. I thought about it from the sense of it's a huge issue, and how do you account for that? I pay attention to, the USDA has the cost of food estimates that they release each month, and so I look at it from there and try to say how much has that changed. But it's not just food, it's everything, right? It's gas, it's housing prices. It's so complicated that sometimes when I do think about it, I tend to be this like big thinker that I feel paralyzed in kind of understanding what is my next step in understanding, knowing that these issues exist. And it's like, what do we do about it? So I don't know, Derek. And if you have some ideas or suggestions and future collaborative opportunities, let's do it. I don't know.
So hi, Jen. I I had just a question, and maybe that's not directly that was looked at in the studies, but looking at, you've been doing this work for a long time. So pre-pandemic versus during pandemic, or I can't really say post-pandemic, but have you seen major differences in how people are how much problems they're having, and even during the interviews or filling the surveys, have we seen any differences?
Yeah, absolutely. So first of all, Raj Shree is one of my first graduate students, and we wrote that review paper together. So I'm so glad that you're here and good to see you. The interviews that I showed here were done kind of pre-pandemic. And so it was done in 2019. And what we wrote up as part of the discussion of that was, it's probably, we have a wealth of evidence showing that a lot of these issues have really changed. Many have exacerbated, but there's not a clear picture of how it has changed too, because people are worried about food. And this is where kind of the intersection is a little bit less clear to me yet, but we can look at tobacco use, and we know that across the population, some people stopped smoking, some people started smoking again, and some people kind of stayed the same. With food insecurity, as you saw in that USDA figure that I showed, across the population, we didn't see the change. And yet when you disaggregate that, we start to see the important changes. And we also had this monumental policy level things that happened in the pandemic that we hadn't had before. We know that the child tax credits really helped families out. The stimulus payments really helped families out. Yeah, it was not a lot if you think about it, but even just that little amount really made a difference. So I think this is something that we're going to be studying for a long time. I don't have a good answer for you, Rachi. So if this is an area that you and I want to collaborate on, let's talk again.
Sure. That's great. Thank you so much, Jen.
There's a question in the chat about where the results of the studies will be posted. And before you answer that, I'll just share that most everyone knows that we will be posting the recording of this seminar onto the PRCHN.org website for anyone who'd like to go back and either watch it again or share the link with anyone who wasn't able to join us today. But Jen, do you want to talk about how you plan to disseminate your results?
Very good. Once these papers are out and all posted, I will talk with Bree and make sure that it ends up linked to the PRC website. So I would say that's the main place to go for these papers. Academics who do this work all the time, we use different search engines, and I know that's not accessible to everybody, nor is it a friendly place. So I'll work with Bree and get this stuff posted in our PRC website. So go there. I see Rebecca Manning has a hand. Yeah.
Awesome. This was a great presentation. I need to get with you and talk about your work because I'm realizing how similar our work is. As you were presenting, I was thinking about built environment. And so, just the accessibility to, tobacco products within the community is kind of divergent when you look at suburban areas. And so I'm wondering how that relates to your findings and how you will incorporate that in maybe future studies.
Really good question. This is where I would, absolutely love to talk with you more, Rebecca, and with Dr. Trappel and Dr. Borowski, because up until this point of my research, I haven't done like explicit analyses of where are the tobacco retailers and what is the density of in terms of the exposure, just the understanding that the experience of food insecurity and tobacco use is not kind of happening randomly, but we see this clustering. And so this is an area that I would love to develop in future proposals. It's getting written up in something that I'm working on right now, but I think this is the right time to have the conversations in advance so that it can be built in as a research question that we can then really investigate. So I don't have a good answer, except that it's a very good question.
Mm-hmm. And I have a question, and I'll just say I don't expect you to have like an answer, but I wanted to share it, because you put up Sarah Mills's paper on sort of the spaghetti model of all the underlying causes, right? And there are a lot of drivers of smoking and cessation. And so, I think we realize that a number of those are not things that we can address in the near term, right? There's sort of longer term issues that require bigger policy solutions. And so, but you've really honed in on the things that are modifiable, right? And that access and utilization are important, and we can do better in those. So I wonder how that sort of, how do you balance? Because I struggle with this sometimes too, and thinking about there are really big issues, or the systems are just completely broken. But I also kind of counter and say, but that doesn't mean we should not do our best for the people who still have needs today.
Yeah, that's such a good question. And so, or just something to think about. And I guess in one of those slides that I had where the concentric circles, I talked about kind of the importance of structural interventions, right? And I'm very inspired by an article that was written by Arlene Brown in American Journal of Public Health, and the role of structural interventions in reducing health disparities. And so there, it's really kind of operationalizing the fundamental causes. And it's about that structural interventions are disease agnostic in their approach. So it's not necessarily about just smoking or diabetes, but it's really, if you address the underlying factor, then you see all of these cascading effects across these health behaviors. So again, a good example of that would be like the child tax credits or the earned income tax credits, where these like larger or minimum wage policies, right? So I think keeping abreast of what's happening in those spaces, or lately I've been very interested in kind of like guaranteed income, base income, that type of, pilot studies that a lot of cities are doing. And so keeping abreast of what's happening there, while you also think about what impact can I have in the space in the small space of work that I do, yeah, Erica, I don't know.
Like I said, I don't expect you to have a good answer, but I recognize that in what you presented, and your intention to contribute. Elaine, I see your hand up.
Yeah, it kind of a little bit parallel to that question is that, and sorry, my internet is a mess, so if you can't hear me, just let me know, Erica.
You're fine.
Okay, all right. It's sort of the question, very good, Jen. I've heard so much of this, but it's always fun to see each step of this project, or where you're thinking on this. So I want to go back to the foundational piece of this, is that it does seem like in a lot of the interviews in that you do see where mental health is also sort of perhaps one of those foundational pieces. And we know in this country, we do very little to actually meet those needs as well. And I'd be curious, have you done any international studies where, not studies, but to look at different countries that potentially you could hold one of these things constant? I'm just curious to know, like if you went to a country where mental health is more covered and or food is more covered, do you see the same mechanism and the same relationships? It just would be curious to kind of because I can't think of how you would do it without actually trying to do these large policy changes. But if you really were trying to understand the social mechanism of how food insecurity and tobacco cessation and even mental health works, could you look at some population that's similar, but where the structural opportunities are different? Just the thought.
Yeah, really, really good question. I can think of off the top of my head studies that have been done in different international contexts, like low middle income countries and high income countries that also are showing this unique relationship or independent association between food insecurity and tobacco use. With the mental health piece, it's not, I know there's at least one study that looked at 149 different countries, and they found the relationship between food insecurity and poor mental health across those countries. To me, I'm not quite sure about like the methodology of collecting mental health, because a lot of mental health is also contextually and culturally driven too.
Yeah,
and so I know that, for example, among Asian Americans or Asian populations, some of those questions and some of those assessment tools are not readily translatable, right? You have to kind of start with that country context. So, but still, despite that, I think they used like Gallup data to find something around mental health. So there is a smattering of research out there around this.
But even looking at countries, I mean, are there countries that do a much better job of providing mental health services to low income residents? Like that'd be the place to start. And then you could look at the intersection of tobacco and food, if that's held constant. That's kind of the concept. You wouldn't have to really measure mental health, but you'd look for where the services are more.
Right.
Because what we don't know is it mental health, or is it just the fact that we have such terrible resources around all four of these things?
Right.
All three of these things, sorry, or four or five, right?
Exactly.
So anyway, I know we're getting to the end, but thank you.
Thank you, Elaine. That's a great question. I have to think about a lot.
Well, Jen, thanks for your presentation. Thank you to the audience for your great questions and Jen for your great responses. Let's all give Jen another round of applause for her presentation today.
Thank you.
Yay. And as I mentioned, the recording of this seminar will be available on PRCHN.org shortly. And we encourage and welcome you to share it across your network. We'll also be posting it on our social and would be happy for you to share and retweet and forward and whatnot. Thanks again. We hope to see you in June for our last PRC seminar for the academic year. And thank you very much. Have a wonderful afternoon.
Hey, everybody.